All right. If you've just tuned in to YouTube, you are behind the scenes. We're getting ready to go live in front of a studio audience via Zoom for Bright Spots in Healthcare's next episode. Thanks for joining us. Here we go. Greetings, everyone. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. A quick special treat today for those of you who are regulars to the show. It's a little bit of a different intro because I want to introduce you to one of my colleagues and one of the producers here at Shared Purpose Connect, Gene Ware. He is actually going to co-moderate with me today. So welcome, Gene.
Thank you, Eric. Hey, well, we're not necessarily going to have co-moderators every episode, but we do want to ensure that if in the rare situation that you, Eric, cannot join, as we have come close, that the audience and the panelists are in some good hands.
Exactly. In fact, I think they're going to be in great hands. Just to give you a quick little background on Gene, he spent well over 10 years working at healthcare conference companies, so he knows a little bit about the business. And maybe even more impressively, at least in my mind, he's a lead singer of a band, and he's also an actor who's been in television series with some A-listers. I don't know. Do you want to name drop a little, Gene, for us?
Sure. Recently, I had a scene in the HBO series Julia about Julia Child, opposite Sarah Lancashire, and I also had a scene opposite Chris Evans in the Apple TV series Defending Jacob. So, I get to play a nosy neighbor and a cabaret singer.
Not, and by the way, neither HBO nor Apple TV is a sponsor of this show, but we just gave them some run. But we welcome you to the front of the microphone, so to speak, and I know you're going to be great.
Well, thanks, Eric. Hey, after being behind the scenes for many episodes, it's exciting to get to be a part of the moderation process, especially for today's topic, 2023 strategy session, member redetermination, CAHPS, and social needs. How's that for a segue?
Well done.
And I also want to say that today our sponsor is Icario. Icario's health action platform unites pioneering technology, data science, and behavioral insights to connect everyone to better health. Check them out at icariohealth.com. That's ICARIO health.com. Now, Eric says this before about these guys, and I totally agree. We view them as one of the unicorns in healthcare because they combine innovation with pragmatic, non-healthcare thinking to drive better healthcare outcomes for all the people you take care of or insure. Now, Eric will tell you more about what I mean by pragmatic, non-healthcare thinking later on in the show.
Well done. All right. I want, for those of you who are new to the show and are attending live via Zoom, we like saying this is your Bright Spots in Healthcare podcast. And to help drive our programming for 2023, we send you a link to a Survey Monkey at about 45 minutes past the hour. We ask you the favor of just taking 3 minutes, multiple choice, to let us know how we're doing and help drive some of our programming for the coming year. You could even let us know how we did as co-moderators, of course, because it's a new format. All right, let's get started here. I want to first introduce you to Steve Wigginton. He is the CEO of Icario. And then I'm going to bring in Menos, and she's the Director of Member Advocacy and Community Outreach Transformation for Horizon Blue Cross Blue Shield of New Jersey. And incidentally, we're not going to do bios for our guests because we do have a lot to cover, but our producer, Sherry Keels, will post in the chat a link to their bios if you want to get a sense of all the great experience you're about to benefit from. But Steve, how are health plans now thinking differently about their relationship with members, especially those harder to reach members that may be right now getting Medicaid benefits?
Yeah, well, first off, Eric, thanks for having me again. It's good to see you, and looking forward to the conversation. And Gene, welcome aboard. It's interesting. I have a unique lens on how health plans are thinking because we work for them and help execute their strategies. And when you ask how are they thinking about member engagement, the first question that I think any of us would ask is, well, for what line of business? Are we talking about Medicaid, the duals, Medicare, the commercial lines of business? The answers are quite different. And I think that's part of the challenge for health plans, particularly that are participating across multiple lines of business. The internal IT needs, the data needs, as you mentioned, hard to reach in Medicaid is a very different challenge than perhaps a Medicare member who's sitting with a broker at the beginning of AEP. And so for plans, I think one of the first things they're doing is making sure they have prioritization around line of business and what are we trying to accomplish. I think the second thing we see a lot of late is this balance between impact, meaning how do I get the members to do the thing that we need them to do, and with yield and how much can I invest and where should I invest, and balancing those two things has become increasingly important. And the yield equation has a little bit of an asterisk next to it we're seeing with our clients, which is abrasion. So I can't just pound a continuous set of outreach against a member without creating some bad experience for that member. And depending on the line of business, that can really be difficulty. So I'd just say impact and yield are very much at the forefront conceptually, and then the line of business is very much the next branch in the tree in terms of plotting strategies.
And when you say line of business, you mean from Medicaid to marketplace? What are we talking about? Okay.
Medicaid, marketplace, MA, duals, so very much an inside baseball term. But in a plan, if I'm running government programs, that may sound like I've consolidated a common set of needs, but in fact, even within that slice, say 50% of healthcare, I might have 9 different slices with very different requirements. And oh, by the way, if I'm in managed Medicaid, even if I'm only in 2 states, I have 2 very different sets of requirements, compliance, regulatory, and otherwise. So that's what I mean by line of business. Yes.
Right. And so, Millie, again, for those of you just joining us, Millie Menos is Director of Member Advocacy and Community Outreach Transformation at Horizon Blue Cross Blue Shield of New Jersey. What are you doing at Horizon that is different as far as reaching hard to reach members, specifically in Medicaid?
I think that one of the things that we do that has brought us pretty great success is understanding that we cover the entire state of New Jersey with a fairly small team, right? Like your members are always going to far outstrip your resources. So really leaning into the relationships with the community partners, you will move from county to county, from neighborhood to neighborhood. Those community partners are really going to stay rooted there. And so the relationships that you build with them, and more importantly, the trust that you build with them has to happen over the course of time, because those are going to be the trusted voices that are going to be your word of mouth, who are going to be there to communicate about any unique benefits you have, who are going to be your resource referrals. So figuring out the best way to meet your community partners' needs in turn meets your members' needs, because these are the places and these are the ways that they navigate their lives with these people, with these partners.
Could you tell me a little bit about how you're thinking about digital and how you're thinking about customizing a digital communication platform for those Medicaid members, and what are some of the components that would make up that digital experience that would make it highly relevant and reason for them to come back?
Yeah. So in Medicaid, we've seen a huge shift in the way that we communicate, right? It was traditionally very brick and mortar available to our members. With COVID, a lot of those brick and mortars closed, and Medicaid was all of a sudden thrust into a very immediate situation in which it realized we have to create digital tools to reach our members and really catch up to the way that these members are communicating already, right? It wasn't that we were trying to be innovative. We were just trying to catch up and provide the tools in the ways that they wanted to communicate. So to that end, this April, Horizon's Medicaid has launched its first mobile application for its Medicaid members. And in that way, we are trying to provide a way to give the information, the plan information, the benefits information, the access to care information in a way and in a place that members have on them all the time, right? So library shuts down, you can't reach the computer, right? A lot of people may not have computers in their home, but we know that almost everyone has a phone, right? And increasingly a mobile phone these days, especially through federal phone programs like SafeLink, and putting a mobile app together for your members is really a recognition that this is the way that they need to access this care, and then layering that application with resources and the things that they frequently call our customer service for, I think is trying to bridge that gap of really providing that retail experience that really has not universally been in the Medicaid space. It maybe is more on the commercial side. You see these retail-like experiences, but we need to get there on the Medicaid side, and this is a step towards that.
As you know, if there's any skeptics in the audience listening right now, like, whoa, Medicaid doesn't use digital, or they don't have this, like, what's some of the like high level goals or utilization goals that you're looking at, and maybe what have you realized so far?
Yeah, so we are at under a year, so still gathering our data, but it's been really interesting to see what features members have really keyed in on. And for the most part, it's those things that they were previously calling customer service for, right? In Medicaid, we have the concept of assigned PCPs, right? So your primary care physician. Not everyone realizes that. And with COVID, a lot of people are first-time Medicaid members, right? So even more so, right? So there's a lot of new members coming onto the Medicaid plan that may not have known the way that Medicaid works, right? So they may not know you have an assigned PCP, you can change that assigned PCP. So letting them know who it is, giving them the ability to change it, giving them a digital version of their member ID card, so that when they go into that physician's office, let's say they left their physical card at home or they've lost it, life happens, right? They have that access to care. They're not going to be denied. They're not going to have to sit in an endless loop of phone calls, right? Trying to get that coverage, confirmation before that they can go to their appointment.
Let me, this is a perfect, John, who's listening right now via Zoom, thank you for this question. I'm going to ask it. Incidentally, folks, if you want to help Gene and I co-moderate, the Q&A modules right there. We should have time to integrate some of your questions into today's discussion. So make sure you throw them in there, and our producer, Sherry Keels, and Gene and I will be on top of it and try to integrate some of them into the conversation. So just a quick follow-up, Millie, like how did Horizon back their community partner resources within their mobile app, or were they able to?
Yeah, so we were able to, and I think that like any piece of technology, we're still growing, we're still iterating. It would not be an app, it would not be any piece of technology if you didn't keep developing and refining it. But in our debut, one of the pieces that we're the most proud of is through a partnership with the Community Food Bank of New Jersey. So this is the largest network of food pantries in New Jersey. And they have started a great initiative, by the way, called Healthy Pantries, that we are supporting to put more 60% produce, meat, right, like not shelf stable stuff into people's hands. And so you go on the app, you can go to their food finder search engine directly from the app, put in your zip code, and you can find food resources, pantries within a certain mile radius of yourself.
Right. How, since rolling it out, I know it's been less than a year, any kind of high level stats for who's actually accessed it or downloaded it or anything like that?
The initial response has been really good. So we, one of the things that we're most pleased about when we look at who's downloading it is prior to the mobile app being rolled out, we've had for quite a number of years now, an online website for that member account. And right now, we're really pleased to report that about 65% of the people who have online web accounts have also downloaded their mobile account as well. And so I think it shows that this is even if you might have had a web account previously, this is the way that you want to interact with your plan on your phone that you always have with you. And it's the same username and password, so no separate account needed. That was another ease of convenience.
Great.
That's great. I would like to bring in Michael Sutton for our next question, if that's all right. Michael. Michael is the managing director for Medicaid policy at Blue Shield, I'm reading wrong, Blue Cross Blue Shield Association. Michael, expanding a bit beyond just Medicaid, how are the Blues as an association approaching duals? And can you provide an example of an exceptional program that combines innovative identification, communication tactics with community-based programs? So basically, how are the Blues building a strategy for duals? Sorry.
Sure. Thank you, Jane. Thank you, Eric, for this opportunity. Yeah, we have identified the DSNP space, right, duals, as a #1 priority for us in our plans. So as an association, we are a member organization of the 34 Blue plans across the country. Even though they're locally owned, we help support them. Of those, 25 are in Medicaid, and a lot of them are in the DSNP space as well. We have about 11 plans that work in both DSNP and in Medicaid. So slowly but surely, we understand that this is what is going to be the driving force for duals in the future. And so we are really trying to hit home for our plans that they want to start pulling together really comprehensive and thoughtful programs for their duals if they haven't already. So for example, we have an amazing plan in Minnesota that actually has been in the DSNP space for years, has been highly successful in both the Medicare and Medicaid space. So the specifics around why they've been so successful seem relatively simple, but when you do something well, you keep doing it. So first and foremost, they assign each member a care coordinator who then is coordinating both the health provisions and the long-term services and supports that you find in Medicaid. And most of those care coordinators are living in the areas where the beneficiaries live. So they're very familiar sort of with the resources that are available for those beneficiaries. And they're able to sort of, it's competent care, right? It's care that meets that person where they're at. There's also a broader focus in the organization on getting members, again, that correct care and at the right time. I think a lot of times it's sort of easy for that particular population to fall through the cracks. And so with that heightened awareness and those care coordinators really making sure that, they're getting the right resources at the right time. And what's great about this is the Minnesota plan is a 5-star plan. They've really gone above and beyond, I think, what many plans are doing with the Medicare piece and again, the duals. Finally, I think this is sort of underrated for some plans, but it's really having an amazing working relationship with your regulatory folks, right? They have a great relationship with the Minnesota Department of Human Services, and that translates into better communication, both on challenges and on, innovations that perhaps you want to incorporate into your program. And it's longstanding, right? The better that relationship is, regardless of sort of the administrative changes that can come in, with any given legislative session. It's great to have that consistency across the program. So those sort of basic fundamental pieces have been very, very successful for them in creating a program that's really solid.
I love that. I see the questions in the Q&A module, folks. Keep them coming. We'll have time towards the end as well. I'm going to hold off on interjecting with the ones that are there right now, but we'll get to them. They're all good questions, and there's different places in the conversation I think they'll be better suited to bring in. Very quickly, folks, I just have a special announcement. I started talking about this a couple of episodes ago, and I'm just super excited about it. We've been doing this show for a little bit over 8 years now, and we're finally going to have our first in-person event August 24th and 25th. I know it seems far away, but not to us. in Boston at the Marriott Long Wharf, right on the water, we're going to host our first executive roundtable summit. We're going to break up a day and a half of time into 5 sessions, one on health equity and social determinants of health, one on reaching hard to reach consumers, one on bright spots in participatory care and engagement. Then we're going to cover consumer centricity, and then finally ROI models and whole person care model programs. And it's going to be like an event you've never attended, unlike any event you've attended before, where we're going to actually start each session with a panel like we have today. And then we're going to break all of our participants into facilitated roundtables. So no slides for a day and a half. If you want slides, this is not the event for you. And it's for payers and providers and our sponsors. And we're actually opening up registration, I think, later today. So I'm super excited about it. It will, we already have a number of confirmed panelists, executives, senior vice presidents, and chief health equity officers at health plans around the country are going to be sitting on these panels, talking to me for 45 minutes, an hour, like this form you're on right now. And then we'll be breaking into those facilitated roundtable discussions. So each person that's at this meeting, hopefully you'll have a chance to meet and be part of a discussion with, to share bright spots and ideas, and hopefully forward your organization into the next year and improving healthcare for everyone. So if you want to get a quick note about that later today or tomorrow, I'm going to put up a poll and we'll send you some information about it, and you could hopefully join us in Boston in this summer. Steve, I want to bring you back into the conversation and talk about star ratings and how health plans are thinking differently about star ratings, especially as it relates to CAHPS. Because actually just last night, right, looks like there's going to be a little bit of shift in star ratings next year potentially. If you're following along your newsletters or you have someone in regulatory policy that has updated you. So how, Steve, do you think health plans need to be thinking differently about CAHPS moving into the next year?
Yeah, well, I'll bridge back a little bit to the comments around the duals. I would agree. A very important population, a population with enough resources around the model, the D-SNP model, to really be able to make significant differences in health and outcomes. And we do a lot of work in the duals area as well on behalf of clients who are very focused there. And stars are a big part of that, whether they're administrative measures or otherwise. I think specific to CAHPS, and obviously you think more about MA in that sense, Medicare Advantage, I'd say it's been a challenge for our clients. I don't think most of the folks that I talk with on a day-to-day basis love the survey mechanism, the limited sample size. It creates some challenges in terms of how confident our clients are with the ratings that are the CAHPS scores that are being generated, which is a conversation for another day. But certainly that's a part of it, right? The measure is a challenging measure, and it's evaluating a broad set of capabilities within the health plan. Like, do we answer the phone on time? Is the provider directory good? So a lot of the folks that we work with in the quality functions are having to branch out to other parts of the building, other parts of the plan in ways that they did not previously and with more intensity. I'd say what we've seen that's been most successful, as with anything, I think from a business standpoint, is go get data. So a lot of our clients are doing lightweight, I don't love the term mock survey or mock CAHPS survey, but that seems to be the inside baseball term. But digging in early in the year, outside the blackout period, late in the year, we have one client who has really taken it to another level. They're doing surveys of members who re-enroll, surveys of people who disenroll. They're doing those in a very lightweight and digital way to get 1,000, 1,500, 2,000 responses. And you've got real data now that you can use inside the plan to action improvements. Hey, our handle times and customer service have got to improve. We're getting killed. That's a better conversation if you're coming with data. So I'd say that's probably been the biggest shift. And then, as you just referenced, it looks like maybe we're going to swing back a little bit here, at least the proposed rule that was released last night, instead of going from a 4-weight, potentially to a 2-weight on that CAHPS measure. We'll see where that all settles out. I think the other thing, just to, as I think about some of our clients who are doing the best work here, fundamentally, the experience, getting data around the experience of your members And then prioritizing your initiatives, your investments, your activities to improve those experiences is good for more than just CAHPS, obviously. It improves the connectedness that those members feel to the plan. Arguably, it improves their health outcomes. The retention rates are higher. So I don't mean in any way to suggest that it's not something to pay attention to. And the way it's weighted now, you need to perform on it.
Yeah, it strikes me. I know certainly in October, excuse me, everyone, when those star ratings were released, I think went from 73% were 4 and above to only 51% this year. And I think that came from a document you guys wrote that I saw that one. And so it strikes me that this would be a good interjection. The folks at Icario wrote a really nice, we'll call it a white paper, but it's not. White paper is very promotional. This is just information on 4 trends that you need to know about around CMS star ratings for 2023. And it gives a lot of high level, really good insights. So if you want a copy of that, you don't want to go through a gated wall and register for anything, we'll send that to you following the show if you want a copy of it. So we'll put up a poll right now and let me know if you want a piece of that. But it was just very interesting talking about how the trends around from 2022 to 23 and where those gaps could potentially be. So an interesting quick read, if I do say so myself. So thanks, Steve, for your team for providing that to us.
Yeah, absolutely.
Yes, thank you, Steve. Michael, getting back to Medicaid, if we can, everybody is preparing for redetermination. Are there certain Blues companies who are approaching redetermination differently or exceptionally well? Or is everyone in the Blues Association going off the same playbook?
So that's a wonderful question, and redetermination certainly, I think, is on the tip of everyone's tongue now and certainly next year. I would say that it varies greatly. I think broadly, most plans are highly engaged as they can be internally to try and prepare for everything that's going to happen. I will say that more broadly, the states are really driving the bus on how much is getting done and how quickly, quite frankly. So it, as I said, varies widely across the states on how that's being addressed. And I don't want to snub Millie and the wonderful work that they're doing in New Jersey. So I know that they're doing some impressive things. But one of our plans, I should say one of the plans, Blue plans in Arizona that we help support, they've really done an amazing job of prepping for redeterminations overall. I will also add that their state has also been incredibly flexible in utilizing the flexibilities that CMS has allowed for getting ready for all of this. First and foremost, the state actually created a community assisters designation, which would allow those that applied to do more up close and personal, if you will, assisting to getting folks either to renew, I should say rather update their contact information or start the renewal process and getting their documents in place. The Blue plan there actually did apply to become an assister and was approved. And so for the first time ever, the plans had access to data that they'd never had access to before in order to sort of complete the loop on those communications with with beneficiaries. So that in and of itself was an aha moment. But because of this, what they've been able to do from an internal standpoint is they've been able to better work with their marketplace colleagues in creating this pipeline of, okay, here's the list of folks that we know that we've received from the state. We're now transitioning those internally to then look at, okay, when the other foot drops, when the other shoe drops, these are the folks that we need to start connecting to ensure that they're not losing coverage. They may be losing Medicaid coverage, but they absolutely could then potentially be eligible for coverage and subsidies on the marketplace. So it's really an important piece of the puzzle to ensure that folks don't lose coverage and that they are able to continue. So it's been, again, a real highlight that we've tried to impress on plans that if this is possible, at minimum, make sure that you're talking to your ACA folks.
Michael, a quick follow-up. I think you answered, there was a question earlier posed by someone in our live audience about, other ways beyond digital community. I think you just that folks are kind of reaching out and getting ready for effectively helping members redetermine. It sounds like you kind of hit on one with the example from Arizona, but they also asked, are there any challenges that aren't discussed regularly that maybe plans need to be ready for as we get closer to this? Are a couple of challenges that maybe are hidden little potholes that we should be thinking about?
Yeah, I mean, there are challenges around information exchange, right? I think that's sort of across the board. There's challenges from a capacity standpoint when it comes to states and their, what their resources are personnel wise and otherwise. I would also say from a plan perspective, one of the biggest challenges is that we are unable to text our members in an opt-out program. Members must opt in to a texting program, which makes it a little difficult when you're working with populations that are difficult to reach. So those are some of the pitfalls, but I will put a little shout out to CMS. They have certainly done an amazing job of trying to produce as much guidance and guidelines for both states and other stakeholders in how to approach this. But as everyone knows, Medicaid programs are significantly different across the board. And so every state is taking a slightly different approach on how they're investing in this.
Awesome. Thank you for that. That is very thorough. I'd like to move over to Steve now. Steve, it stands to reason that whether the PHE ends shortly or not, the core components to engaging and educating members in general is competency. Like, plans must get better at executing. Do you have an example or two of health plans who are advancing their capabilities to this end, depending on when the PHE ends?
Yeah, a lot of them, and I think Michael just touched on a couple that we've seen. I think maybe one opening comment, particularly those plans that are working in multiple markets. The level of complexity, multiple states, multiple markets, the level of complexity goes up as they have to navigate not one centralized solution that will work for every market that they operate in, but instead have to balance across. But I'd say generally what the two that come to mind, one that very much heavily involved in both duals and managed Medicaid and has a very strong exchange offering. The comment that Michael made is definitely spot on. Thinking about the continuum of where these members could ultimately land and get coverage, and proactively thinking through strategies internally to lubricate that movement if and when the time comes. I'd say the second example, another example that comes to mind that they've really pressed forward on is they're not waiting. So the comments around, again, Michael made around certain states are being more flexible, more proactive. Other states are not, maybe not rooting for a lot of continuous enrollment. And you can imagine how those states break out. But certainly getting proactive about getting opted in text messaging consents. That's something that you can do long before the PHE expires. And thinking about not necessarily developing relationships with members, which is a very high bar, but at minimum driving some level of connectedness and working consistently on that, identifying a centralized data store, a system of record, if you will, a system of truth that doesn't get overwritten by the state every month when they send you a fresh batch of data, and really thinking as more of a journey around being connected, and then building on that connectedness to be able to drive action. So this idea that you are eligible for an exchange product as a for instance is a form of action. It's quite complicated. A simple action is, hey, we want to make sure we have the right mobile number that we can text you, and will you please confirm that this number works? So we've seen a lot of proactive strategies, and I think in the middle of last year, a lot of urgency without necessarily a coherent medium to long-term plan. And what we see now is a lot of really thoughtful planning, and I think an expectation that activities are going to launch even before the PHE expires, to the extent that they are possible in the regulatory framework.
I've got a quick follow-up, Steve, for you or Mikal. Do you have a reference to share with the group where it was determined that payers must follow an opt-in versus an opt-out on SMS communications?
So, and Steve, feel free to jump in. So I say managed care plans. It's actually through the Telephone Consumer Protection Act that gives those guidelines, and that's overseen by the FCC. It is something that actually HHS has requested FCC revisit because providers are carved out from falling under the TCPA. However, it's our understanding that FCC is hesitant to open that up. Mainly their concern is around spam, scamming, those types of things going to a vulnerable population. So it remains to be seen if there will be some additional guidance or even, leniency in those rules, but that's what governs what plans must follow.
Yeah, TCPA is a fundamental game changer for any business that wants to communicate either via telephone or text message or SMS with anyone. It is probably the part of Icario's business that has grown and developed the most, because our clients are coming to us and saying, how do we tiptoe through what is not an entirely clear set of guidelines? TCPA represents a lot of change for a lot of folks that have done digital communications in prior pre-TCPA, but it's a real thing. I would say that it's not as simple as you must opt in or not opt in. There are very different use cases. There's specific guidelines for each. And I would just say the bar is going to continue to go up. So plans are going to need to be able to communicate outside of a spam designation. They're likely going to need some help with that. And TCPA will continue to be a central part of how they execute, or I should say being compliant with TCPA.
That sets me up very nicely. So I want to, Gene mentioned in the beginning that Icario is our sponsor, and I wanted to take some time to tell you a little bit more about them. If you've been listening to this show since 2020, I'm a huge fan of this organization. If you haven't heard of them, they are a health action company that deeply understands people by using behavioral research and data science to move individuals to take action for better health. Their goal is to bring humanity back into healthcare communication by delivering a whole person solution by intelligently reaching members that need the healthcare interventions most, while at the same time drawing lower and moderately acute members to action with personalized outreach, but doing it at scale. And so I always like saying they provide a really pragmatic yet non-healthcare approach to consumer marketing. I like saying they deliver sort of a Madison Avenue approach to understanding different consumers' values. It's one of the reasons I'm such a big advocate of this organization, because I just think we have to be thinking differently about how we engage our consumers in healthcare versus everyone else. When you see the words that companies use, like Coke or Apple or Tesla or Target, or all these companies that kind of reach us and drive us to behavioral change each and every day to consume their brands, we need to be taking that fundamentally provenly successful approach to healthcare, and because the principles are the same. So if you want to move the needle in your population health, whether it be value-based care, whether it be focusing on redetermination, CAHPS, MA stuff, you just need to think differently about how you're communicating with your market. And I encourage you to check out Icario. I'm going to spell that for you, ICARIO.health.com. And if you want to actually meet them, that survey I told you about, that's going to be coming out in about 6 minutes, you just click on a box. I'll personally introduce you to some of the folks on their team so you can learn a little bit more about how they think about behavioral change and communications out to the healthcare marketplace, the consumers that you're trying to reach all the time. So you can check them out. I want to bring Mikal back into the conversation, and Mikal, what's an example or examples? I'd love some examples, maybe, since you represent the whole Blues Association, of maybe some innovative programs that we will see that maybe we'll see more of, whether it be through the Blues family or even outside of the Blues family, as it relates to both Medicaid and also like social needs in general.
Sure. I mean, I am very lucky to work with some amazing plans that are doing some really innovative and amazing things, particularly around social needs. A few come to mind. I think first and foremost, there's always a focus on food, transportation, housing, right? Those are sort of the top social needs. But there's also been a shift into looking at Indigenous populations and their unique health needs. There's been a shift in really focusing on maternal health needs. So we do have the opportunity to view many of our Blue plans and what they're doing. Healthy Blue in North Carolina has an amazing program that they've created where they actually have a tribal member embedded in their care coordination team that acts as a liaison for their organization to better understand what it is the needs are and how they are different. Obviously, culturally competent care is hugely important and something that I think most plans are considering, if not implementing. But Healthy Blues had this program up and running for about 1.5 years now, and it's by all accounts very successful in getting the other side of the story, right? Again, that whole person care and meeting people where they're at. Transitioning into maternal care, we have the Blues in Minnesota again. They just completed a pilot where they identified, they have a large Somali population in parts of Minnesota. They identified new mothers that were in need of nutritional support during their pregnancy. They actually outreach to Somali restaurants in the local areas to create a program where these women not only receive nutritional food and supports, food boxes, depending on their level of comfort with preparing food, but also food for the family, because they were finding that moms were not necessarily eating what they were getting, but saving it for, other children, other family members in the household. So they pivoted, if you will, and incorporated food for all the family from 20 weeks gestation through postpartum. So really wonderful. Haven't seen any results yet, but just the concept is really new and exciting. And then now I can highlight New Jersey and some of the great things that they're doing. New Jersey has done, and Millie especially and her team have done an amazing job highlighting the need for doulas in the maternal health space. And again, specifically, culturally competent. Studies have shown that when you look like the person that's helping you deliver your baby, that the outcomes are significantly higher. So I'll kind of stop there because those are some really great highlights, but I would love Millie to maybe go a little deeper on her doula program.
Go ahead, Millie.
Sure. Thanks for teeing me up, Mikal.
Michael's got this. She's
yeah.
I love it.
High five. We're doing this.
Doing your job, Eric. Yeah. So I think that, when we talk about health equity and the need to be culturally competent in our programming, doulas is a great example of that, right? So maternal health is at a crisis point in this country. The latest maternal health survey that's come out this year shows that actually the statistics are only getting worse in terms of maternal morbidity. And in New Jersey, it's a problem that we especially face, right? So right now we are ranked 48th in the nation for maternal mortality. And our First Lady, Tammy Murphy, has really taken this as her platform issue. At Horizon, we are committed to reducing health inequity on the basis of racial disparity. And through that has really come support for a cross-cutting doula program, right? So New Jersey, through the Medicaid contract, brought in doula benefits, one of the first in the nation to do so. And we have had that benefit in place for about 2 years now, coming on 2 years. And the support that doulas can provide, I think still needs to be better known. But anyone who has had an experience with a doula, I mean, they can't stop speaking about it, the way that it has positively impacted and transformed their birth experience. So doulas are not medical providers. They are folks that are there to help the vulnerable time that a birthing individual faces, right? And more importantly, like, to talk about what can be done as an extension of the plan. While a plan may reach someone telephonically, a doula is entering someone's home, right? They're creating a bond with the person. So if they see that the person is in need, they are an extension and a resource referral back to the plan, right? Oh, we have a food security issue. We maybe have some behavioral health needs that could really use some treatment and some addressing. This person needs support in breastfeeding, lactation support, right? So that way, and that trust that's developed, I think it's easy to brush off a telephonic question, right? Like, there are these screenings that are in place, and I think everyone is really trying to do the right thing, and they do have success. But I don't think there's any substitute for a trusted voice being there with the birthing individual. This starts before the delivery, right? Through the prenatal period, there at the delivery, and then most importantly for maternal health, in the postpartum period as well, which is actually where most maternal mortality occurs, which is not well known, but in the postpartum period. So making sure that you get that doctor's visit within 6 weeks of delivery, right? Having that checkup, having that support, and making sure that everything is okay in the home environment for, child to return home, and healthy parent, healthy child. So we have started that. And then we're really proud to announce that starting January 1st, we've actually taken the model that Medicaid has built, and we're also bringing it to our state exchange. And when we talk about that, that's just a recognition that these issues, these health equity issues, they're cross-cutting. They're not just Medicaid issues, right? When we talk about food security, housing insecurity, we can't just say, oh, these are Medicaid issues and leave it at the door. We have to provide support across the spectrum of the populations that we serve.
Wow, that is amazing. That work sounds so incredible. I feel like a chump having to jump in and promote our next episode, because that's way heavier than but let me just say, just to give everyone a reminder, our next live episode is going to be on January 12th, 2023. Our topic, ACO Reach, Advancing Equity and Optimizing Performance. If you'd like to attend, we're going to put up a poll. Our senior producer, Sherry Keels, will put up a poll. Just click yes. We'll get you registered, and you won't have to take any further action. You won't have to go through the registration process. Millie, I would love to ask a follow-up question. It's kind of a bit of a follow-up. So it's clear that plans around the country are at different stages in their evolutions toward local as a healthcare strategy. So how can CEOs and other listeners, the leaders listening right now, create a strong culture of community outreach and truly make health equity part of their overall business strategy? Like, could you give me maybe, 3 or 4 pillars in your blueprint or something like that? The floor is yours.
Yeah. Thank you for the question. And this first one, I know it's going to sound really obvious, but it's missed more often than you think. You have to invest in it. Like, you have to make the conscious decision that we are going to support this. We're going to dedicate funding to it. It's going to be part of our budget, and we're going to have measurable goals around it, right? So there's going to be accountability. So it's not just talking points, and it's not just being able to say, yes, we're committed to it. We've put out a social media message, that there are real actions and commitments from the organization as a whole around it. And that starts from enabling your teams and your departments to be able to have the resources they need to either, partner with vendors to support community organizations to stand up these innovative programs. So I would say that's one, which is obvious, but sometimes not present, which is, consciously investing and planning around it. Secondly, I think the realization, and I touched a little bit on this before, that your populations, especially Medicaid populations, are not a static population. It's a fluid population, and you have to account for that. So when we launch the doula benefit, which will be happening in January on the state exchange, it was in recognition of the fact that this is the population that most often flows in and out of Medicaid, right? There's a concept out there of the working poor, which is very, very real, right? You have a job, you don't technically qualify for Medicaid, but one change and you're back on Medicaid, right? So these are folks whose lives are not, they're not super solid. One single change, one single derailment, one accident, as it could happen to any of us, frankly, right? That's what that safety net of Medicaid, I'm sorry, is there to do. And being aware of that and having the vision, especially if you're a company that has multiple lines of business, to know that these issues are present amongst your other lines of business. They may even be present in your employee population, right? And standing up awareness and equity programming that addresses folks, across all the stages that your company offers. Those are just a few. I'd say the last one, if I had to choose a third, is really knowing that you have a specialty, right? You are the person who understands health insurance when very few other people do. It is a super, super complicated business. And it is that gift of education that you can bring is so valuable. So any health education that you can provide and care navigation that you can provide, especially to the nonprofits and the CBOs that you work with, they appreciate it, right? They have clientele that are in need of it, and staying in contact with them about new benefits, about that concierge service to navigate the system is more valuable than you realize.
Can I summarize that? Because I think I heard three things: invest in the outreach and be accountable.
Yeah.
Make sure that the team and the process is built around the awareness that new issues and life happens. And so your populations are going to be fluid. Individuals are going to change in and out of eligibility. And third, and finally, embrace the fact that we're a educator of health insurance. I would promote, hire someone from USA Today. I always thought that they produced really easy to read and follow content, but make sure that we're educating members and not actually talking over them, but talking with them and to them in their language so they can understand it. Did that capture all of that?
Absolutely.
All right. I know we're closing in at the top of the hour. We have a couple of other questions I want to get to. Steve, I want to stay I just want to stay up high now, sort of in the C-suite. When thinking about any strategy, I know we have to make difficult decisions about resource allocation. I mean, just shifting something around product or tactic, changes the mind share of the team. So where we focus resources, I think you used the word yield early on, in the show, where we focus our resources to generate the best possible yield of our efforts. How do we do that? And how do we make sure that we're keeping our opportunity costs close to zero? So how are health plans thinking about this and actually executing strategies when it comes to outreach to generate the most yield and leave as little on the table as possible?
Yeah, well, I think Millie touched on it just a bit, right? Begin with the end in mind. So the plans that we see doing really strong work, driving strong outcomes that they can measure, they do have an end state vision. So just to borrow a little bit from Millie's comments, we see that our membership is moving between Medicaid and the marketplace. All right, that is a fact. What are the elements of our strategy that we want to design around that fact? How are we going to measure them? What do we forecast the outcomes or the yield to be for those initiatives? And then staying very vigilant about that measurement. I think the other thing we see a lot is this idea of connecting the dots. And when I say we see it a lot, in the best examples, some of the ones that Mikal mentioned are examples as well, where we have a client that has a very strong position in the D-SNP market. They interact with those members at sign up. They interact with those members. Many of those members get a home health visit at some point early in the year. Some of those members, they ask us to reach out and get in touch with and get information from. But they are orchestrating all of those touch points very thoughtfully. And that is a big part of how you drive better yield. If I'm going to have an individual, a doula or a care navigator or a home health nurse that's going to go in the home and visit a member, there's a whole bunch of things I can get done in that visit that benefit my quality measures, that could benefit my CAHPS score if it's an MA member. And the best examples that we see for driving resource efficiency and outcomes, which is really what we all do for a living, is try to get the most out of each dollar we can on behalf of the members we serve. They are connecting those dots, and they're holding internal stakeholders, and in the case of Icario, external stakeholders accountable for being connected, for sharing information back so that there's not duplication. You're not creating confusion, to the education point. When I educate, one of the lines of business that we support a lot, managed Medicaid, this concept of value-added benefits, if not properly executed, you can turn a good thing into a bad thing, because I actually confuse the member and they don't understand how to access the benefit. And so here's something that should be good for you that creates a feeling of resentment or frustration. So the orchestration and the prioritization of all of the different touch points, making sure you don't get duplication and measuring the efficacy of each of those, that's a never-ending challenge. That's a journey. But the plans that we see doing the most with the least have those things front and center.
Awesome. Mikal, I'd love to sneak in one final question. I know we're closing it. So I'm just curious. I think everyone would love to hear your big picture thoughts on how should our listeners be thinking about redetermination? Like, is this a little adjustment to business as usual, or are we talking about something different, larger?
It's huge. It's probably the biggest thing to hit the Medicaid program ever. There have been studies that have shown estimates of 15 to 18 million people could potentially lose coverage. Much like I spoke about earlier, right? That transition, warm handoff to the marketplace is hugely important. But of those 15 to 18 million, half of those are children. And so if that doesn't strike the fear of everything into you, it should. So I think just the sheer number of people that are at risk during this process is huge. But also, ensuring that people know about it. There's also been, recent studies that there's really very little education from a beneficiary perspective as to what's coming down the pike. So that's, it's a lot to think about with the numbers and how it's all going to turn out. So challenging for sure.
I'm not going to quote you, and just between you and me, Mikal,
Chickens.
What's your guess? I know it's a guess on how this is going to play out from a PHE standpoint, timing wise.
Yeah, I think that there's a ton of political pressure to end this. I think that barring any catastrophic increase in RSV and flu and of course COVID during this winter, that there's a high likelihood that the public health emergency would end in April. HHS has guaranteed states that they would have a 60-day notice. And so that date to circle on your calendar is February 11th. We will know if HHS does give that announcement, then yes, it will end in April. If we hear nothing that day, then that means it will be extended for another 90 days. So my inclination, my crystal ball is that it will end in April, but you never know.
Great stuff. I posted something for our live listeners in the chat. We'll try to get some written answers to some of those questions we didn't get to. We did run a tail end a little bit longer than I had estimated, but this was super impressive, super great, lots of information in an hour. So I just want to thank the three of you for taking all the effort and time to prepare for this, and also to take the hour in the middle of your day. So thank you for that. To everyone who's listening, whether you be listening live via Zoom or whether you're taking a walk or in the car listening to the podcast, we do really appreciate the hour you spend with us. We don't take the time in your busy day that you take with us. We take that very seriously, and we don't want to take that for granted at all. And Gene, great job for a show. So congratulations on that. We do this show, folks, with the sole objective of providing all you with ideas and insights to help you in your current role. So please tell your friends and colleagues to subscribe to the show. Let us know what else we could do to cover better content for you, to be better. You could take that survey I just emailed you. If you're listening on the podcast, email me at eglazer@sharedpurposeconnect.com. I look at all the emails. I reply to all of them. Most of them. Be nice. No, I need constructive feedback, so send them to me. Dare to be different. Dare to push these ideas. Push your organization outside the box. And remember that this is your Bright Spots in Healthcare podcast. Have a great day, everyone.